So while Dr. Kahn is getting set up for the next talk, I've learned by hanging out with these imaging people that they really like movies. And so showing the movie on their own computer is an important element here. But while Andy's getting set up, I wanted to again mention that Mr. Don, who is the trustee for the Macklin Foundation that is funding all of this work, is here with us today. We'd love to have you come up and introduce yourselves to Mr. Don and thank him, as all of us have thanked him, for the his foundation's support of this research, because research takes money. We have families and mortgages. We have to pay the bills. We have laboratories. All of these costs are things that we have to fund or pay for through grant support. That's how we live. So granting is obviously a very important part of it. And the last speaker, second to last speaker in our group this morning is going to be Dr. Catherine Taubert from the American Heart Association. I know a lot of you have come up to me and asked, how can we get more research for Kawasaki disease? And so what Dr. Taubert is going to do is explain a little bit about how funding works on a competitive basis, how the American Heart Association works. And I think you'll understand why it's difficult to get grants to work on Kawasaki disease. So without further ado, I'd like to welcome Dr. Kahn, who's an assistant professor in the Department of Medicine. He also has a PhD in physics. And as he begins to go through the images, I think you'll understand why it's useful to have that kind of very quantitative background. So Andy, thanks for joining us.
Okay, well, thank you very much for having me. So I'm going to take this opportunity to discuss cardiac imaging, how it relates to Kawasaki disease, review some of the imaging modalities we use, and also talk about how we would use them in the adult KD collaborative research project that Dr. Daniels talked about. Okay. So first of all, this has already been alluded to a number of times today. Just as a way of background, our motivation for doing this is this growing realization that although Kawasaki disease was initially thought to be a self-limited disease, actually we know now that patients who have Kawasaki disease are at risk for further complications down the road, and these may include coronary artery blockages, may include scarring of the heart muscle, or impaired heart function. And again, this is probably a small minority, but we want to be able to catch them and treat them and decide what is best for these patients. And the other important point to make is that we're realizing that the cardiac damage that can occur can be silent until very late. And so because of that, we think it's very important to use imaging, which allows us to get a look at what's going on in the heart, because we can't always wait for symptoms and wait for patients to come to us. Okay, so when we think about advanced cardiac imaging in patients, what we're hoping to do is to detect the changes that are occurring in the heart and blood vessels before there are symptoms. Okay? And in doing so, we would identify the patients who are at increased risk, and then we can stratify them and get them the appropriate treatments, and so on. Now, in terms of imaging the heart, there's a lot of information we can get by imaging the heart. So I'm just going to very briefly summarize. We can look at the heart walls. We can look at the function of the heart in the chambers and see how well the heart squeezes. We can look at the valves and the function of the heart valves. And we can look at the blood vessels, either the smaller vessels like the arteries that supply the heart, or big vessels like the aorta and other great vessels that go to and from the heart. Now, there are other things in addition, but these are sort of the main big points. Now, when we think about the different imaging modalities, there are really 4 imaging modalities that we use to look at the heart. And you've already heard some about actually each of these already this morning. So echo, or ultrasound, is sort of the most established imaging modality. And I'll talk a little bit more about that. And most of you already, I think, have been introduced to that. MRI and CT are newer modalities, but also provide very important information. And then nuclear is primarily used for stress testing. And I'm actually not going to talk I'm not going to talk further about nuclear just due to time constraints and because we're not doing that as part of our research collaborative. The other thing I think that needs to be said is that all of these modalities are really complementary. So we get different information from each of these, and that's why the ordering of these tests is often individualized for different patients. In terms of safety, the one other comment I'll make is that echo and MRI are essentially completely harmless tests. CT has some radiation. Nuclear usually has the highest radiation of the 4 tests, depending on how the CT and nuclear are done. Okay, so briefly, let me just first mention echocardiography. And again, you've already heard about it, and many of you have already been introduced to it directly. So in echocardiography, it's really the same test that we use to look at a baby in a mother's womb, just about a foot higher on the body, okay? So, in doing so, a sonographer takes a probe, holds it up against the chest wall, and uses high-frequency sound waves to make pictures. And then the pictures show up on the screen, and she'll take, or he will take a number of different pictures in a whole bunch of different views, and we get a lot of images, usually about 40 images or so, depending on what's happening with the patient. So this is a very established technology. It's very safe. It's harmless. As was mentioned earlier, for small children, sometimes sedation is required. So we get a very good look at the heart size and function. We get a good look at the valves. But the other point I want to make is the coronary arteries, although they are well seen in children, and it's a great modality for looking at the arteries in children, in adults we can't rely on this because as body size gets bigger, we actually can't see the coronary arteries well at all. So we get indirect information about the arteries, but we don't directly visualize them well at all. Okay, so here's an example of an echocardiogram. And again, we use a whole bunch of different views. This is what we call the 4-chamber view. And this is an echo from a normal patient. And so you can see here's one of the valves. This is the mitral valve. This is the left ventricle, which is the main squeezing chamber of the heart. Left atrium, right ventricle, right atrium here. And here's another valve, the tricuspid valve. So again, what we see here is we see the walls coming in nicely and uniformly, and this is normal heart function. Now we can also take, as I mentioned, different views. So one view we often take is where we cut across like this, and then we only, sorry, let me get to that in a second. So let me just show also an example of an abnormal heart. So this is the same normal heart I just showed you, and here's a patient. And you can see this patient, this is not a Kawasaki patient, by the way, but this is a patient with a cardiomyopathy, with a dysfunctional heart. And you can see here that the heart squeeze is significantly impaired compared to the normal patient. Now we are realizing that a very small number of Kawasaki patients may be at risk for having impaired heart function like this, and this is one of the reasons why we want to do the various testing that we're talking about. Okay. Now here's another view, and this is what I mentioned earlier, where we cut across, and now again we see the left ventricle in cross-section, and here it's a circle, and we see the circle get smaller, and then in the impaired heart function here, we see that the degree of thickening, the degree of contraction is much, much less. Okay? So this is a very sick heart, and again, this is something that we want to identify, try and prevent from happening, and if it does happen, figure out how to treat it. Okay, now let me move on to MRI. So MRI is a newer modality for sure, but one that we do have a significant amount of experience with at this point. It uses very powerful magnets and to produce images, and the actually technical part of how MRI works is very complicated, but it's amazing that it works so well. The good thing about it is it uses no radiation, and it's essentially a completely harmless test. We do give contrast media, usually with the MRI, but that contrast media for people with normal kidneys, which is true of almost all Kawasaki patients, is completely harmless. And so it takes about an hour. If somebody has claustrophobia, that can be an issue, but otherwise, it's usually not a problem. So what can we learn from MRI? There's really a lot of things that we can learn. We can get another good look at the heart function. We can directly visualize scar and fibrosis. So rather than other modalities, we're trying to infer fibrosis. Here we can actually look at it. We can characterize the heart tissue. We can image heart valves. We can image the coronary arteries. And we can also look at other large vessels. So here's an example of an MRI. And again, this is the same view that I showed you earlier with the echo, the 4-chamber view. And here, as you can see, we see the heart muscle, which is this darker region, thickening. And we can see it very, very well with this technique. Now again, we can look at other views. So if we cut across, we can use that same short axis view here with the left ventricle here. And you can see it all, and this is a normal, and we can see the circle getting smaller uniformly. Now we can compare that to somebody who's had a heart attack, for instance, in which case we will see a region of the heart that doesn't thicken normally. So here's an example of somebody who's had a heart attack. And here you can see that this bottom part of the heart here is not thickening at all, and the top part is. So this is the result of that heart attack. This is, by the way, not a Kawasaki patient, but I just brought it because it's a good example showing this abnormality. Okay. Now, another thing we can do with these images then is we can take them and we can post-process them, and there's some very fancy programs out there. Because we see the muscle so well, we can then do very precise measurements. And so this is considered the most precise way to measure the heart function, and this is just an example of one of those programs. Another thing we can do is we can give intravenous contrast, and we can take pictures while we give the contrast and after we give the contrast. So this is an example of the heart in that short axis view with the left ventricle here, where we're giving contrast, which is shows up as white here. And what we're looking at here, primarily when we do this, is we're looking at the muscle here, which is out here, and we want to see whether it blushes uniformly or abnormally, or doesn't blush uniformly. And if it blushes abnormally, that suggests that there's a region that's not getting enough blood flow. And in this heart, which again is not a Kawasaki patient, you see there's a region here which stays dark compared to the other regions. So this is a region that's not getting enough blood flow. And so again, this is something we can visualize directly. We can also take pictures after we give the contrast, and then we can look at different patterns. Normally what we would see with appropriate imaging parameters is that the muscle should be dark, should be essentially black, as you see here. And then we look for regions that are not black and that are in fact white, and that indicates a region of scar. So this is somebody who's had a heart attack here, and this lateral portion of the heart shows up as a white region. So this is what happens when somebody has a heart attack due to a blockage of the artery supplying the heart. Conversely, we can see other patterns that are abnormal when we look after we give the contrast, and we can sometimes see patterns of scar from inflammation. And this has been described not only in one case report in Kawasaki, but is known to happen in myocarditis, inflammation of the heart muscle. So we think this may happen more broadly in Kawasaki disease. And so this is an example of a pattern, and you can see this is a very different pattern. This scar, this white line here, is not along the inside border, and it's more irregular than in the case of the person who's had a scar from a heart attack. Now this is an example of somebody who has had a heart attack from Kawasaki disease. This is a 12-year-old patient, and you can see here's the normal dark region of the heart, which shows normal muscle, and here this bottom portion of the heart is thinned out, and you see this white line here, and that's the scar. So again, using this technique, we can directly visualize the scar from the heart attack. Now MRI is used to look at the coronary arteries directly. Here's an example in a normal patient. These are pictures we took at UCSD, and here's an abnormal patient, both with Kawasaki disease, with dilation of the coronary artery. To use MRI to do this is technically challenging. People, to be honest, get mixed results, but the attractive feature of this is, again, it's completely harmless. Now, these pictures generally are not quite as good as the best pictures we can get with CT, so there are trade-offs involved. So let me talk briefly about CT lastly. So CT uses X-rays, and it takes a whole bunch of X-rays using a beam that rotates around the patient, and then it uses a computer to put it all together and make some very high-resolution pictures in multiple different imaging planes. So it involves radiation. It does involve dye. This dye, again, is generally harmless for people, as with almost all Kawasaki patients who have normal kidneys. And it takes actually just a few minutes. It's quicker than an MRI. So the main use of the CT at this point is to directly visualize the blood vessels. And the other use is to do calcium scoring, which is to visualize, to see how much calcium has built up in the blood vessels. So we can either, and to do that, we don't give contrast, or we can give contrast and then look at the lumens of the arteries themselves. So briefly, coronary artery calcium score, as Dr. Daniels mentioned, is something that you might have seen advertised on TV and is often advertised as a screening tool for adults and can now be used for Kawasaki disease. And the idea is that calcification can serve as a marker of arteries that have been damaged. And if there's higher calcium and a higher score, then that, we think, might be something that predicts events, but we don't know, and that's why we're doing this research. Now, this is a very low radiation study and is done without contrast. Very quick, just a few minutes on the table. And here's an example. So this is an adult who does not have Kawasaki disease. Here's a coronary artery, and you can see some calcification in there. And then we add up how much calcification is there, and we come up with a total score. And the higher the score, at least for people in adults with atherosclerotic heart disease, the worse the prognosis. We don't know yet for Kawasaki disease. Here is an example from the literature of a patient with Kawasaki disease who had severe aneurysms, and here you can see marked calcification of the coronary arteries. Now, the other way we use CT then is to do angiography. So in this case, we inject contrast while we take our picture, and we take we do direct imaging of the coronary arteries themselves. So when we do this, we're going to give the contrast. We often will give medication to slow the heart rate down a little bit before we do this because the heart's moving, and in order to get the best pictures, we want it to move a little bit slower than usual. Now, this does involve radiation. The radiation dose is something that we take very, very seriously, and we try and minimize that. And so it depends on the patient's size and the technique used. Radiation dose can be, using the latest techniques like we have at UCSD, is about 1 to 5 millisieverts is the unit. Now, everyone's like, what's a millisievert? So to put that in perspective, I always like to think in terms of how much radiation we get from the sun. So usually we get about, and this is the national statistic, San Diego is probably much higher, but okay. But 3.6 millisieverts a year is what's typically quoted as what you get from the sun. To put it in another perspective, a mammogram, which a lot of women get every year, is 0.7 millisieverts. So this is somewhere, I like to say, it's maybe a few months worth of solar radiation, maybe as much as a year, maybe even a little bit more, depending on the body habits of the patient and the technique used. But we get great pictures. So here's an example of a normal CT, and here you can see we see the arteries very, very well, and here we've laid out one of the arteries using a different display technique, and you can see this is a normal CT. And by contrast, here's an example of a Kawasaki patient who has marked dilatation of the coronary arteries, and you can see there's aneurysms of both the right and the left coronary arteries, and we can see these very, very well and define the anatomy using this technique. Okay, so finally, let me just conclude by mentioning the analyses that we're going to do. For the research study, our plan is to take these different tools and then to correlate them with all the other data that Dr. Daniels talked about. So we'll take this data, we'll correlate it with the data from the patient's acute presentation, the biomarkers, the vascular function, the blood vessel function she talked about with the blood pressure cuff, and then also look at subsequent clinical events by following up patients. Now, of course, the other thing I know that you want to know is, well, how can we use this imaging data to care for patients? And that has to be really individualized. So it's hard to make generalizations, but since we can see the heart function, if there is impaired heart function, then we have to think very carefully about why it's impaired and what can we do about it. And in some cases, that will be medicines. In some cases, it will be evaluating the coronary arteries and thinking if the patient needs some procedure to improve the blood flow to the heart. If we see a scar, again, then we're going to think carefully about why there's a scar, what medicines the patient should be on, and whether we should do a procedure to see the coronary arteries even better. And then if we see narrowing of the arteries, in some cases we treat that with medicines. Some cases we do angioplasty or stent, like Dr. Gordon does, or in some cases we refer the patient to actually have bypass surgery. And then in addition, as many of you know, if we do see dilated arteries, that's also an indication for blood thinning medicine. So that's important to document as well. And I'll stop there. Thank you very much.